My name is Dr. Ted Gregorius. I want to thank Hoag Orthopedic Institute for having me as a guest tonight to discuss rotator cuff injuries and treatment options. So tonight we're going to review injuries of the rotator cuff, how to make the diagnosis, and then what the various treatment options are. Before I get started, just a little brief history on myself. I've been in practice for about 15 years. I'm a member of California Orthopedic Specialists in Newport Beach. I trained locally here in Southern California at Loma Linda University, and then at University of Florida, as well as Stanford University, with a subspecialty in orthopedic surgery with emphasis in sports medicine. So having said that, let's get started and go ahead and look at some of our first illustrations about the shoulder. So looking at our first slide, we're looking at the basic anatomy of the shoulder. So before we get into the rotator cuff, I wanted to talk about the bony anatomy, which is the underlying anatomy of the shoulder. It's important to understand it, particularly with the ball and socket joint of the shoulder. So there's really essential three bones that are important to us this evening to reference. And one is the clavicle. And if you look at the right-hand side of your screen, you're going to see right shoulder that's looking directly at us, and then on the left-hand side of your screen, you're going to see a shoulder looking away from us. Both are right shoulders. So the ball and socket joint of the shoulder is comprised of the humerus bone and then the scapula bone, which has the glenoid. And so the two important parts of the shoulder that we want to understand is the way the relationship is between the glenohumeral joint, or the ball and socket, and how it forms a coupling mechanism with the shoulder. So again, that's the clavicle, the humerus, and the glenoid, or portion of the scapula. So our next slide looks at the four muscles of the rotator cuff. And these are often confusing to patients and other folks looking at the rotator cuff. People refer to it as the rotator cup or various other descriptions, but it's actually the rotator cuff, C-U-F-F cuff. So there's four muscle and tendon groups that form the rotator cuff. In the front, on the right-hand side of the screen, you'll see the subscapularis muscle. That's the largest portion of the rotator cuff, and that's the front muscle. The muscle on top is called the supraspinatus muscle and the tendon belly, and then the two tendons in back are the infraspinatus and the teres minor. So the four tendons about the shoulder form the rotator cuff, and they form a very important linkage system to create a coupling, almost like a ball and hitch, to hold the ball in the socket. So the bigger muscle, which we'll look in the next screen, is the deltoid. So if we move along here, we're going to see another slide also looking at our right shoulder. It's looking at us from the front to back, and we can see that the rotator cuff is underneath the deltoid. So we see the large tendon in front, which is the subscapularis tendon. And again, we can see how if the ball and joint socket is held in place and that joint is coupled, the deltoid can then function. And the deltoid needs to be stretched out to its proper length in order for the rotator cuff to function, hold the ball and socket together. So our next slide illustrates the mechanisms of these various muscles, and there's three principal force vectors around the shoulder. So the first two that you see on the central portion of the screen is the supraspinatus and then the three remaining muscles. So they create a rolling and sliding mechanism to hold the coupling into the joint. And then that allows the deltoid to help lift the arm. So if the rotator cuff is not holding the joint, the head will slide upward, creating secondary impingement or pain in the shoulder. So this is important in understanding how a rotator cuff tear will affect the motions about the shoulder. So it's a little bit complicated at first, but it'll make more sense as we go along. So looking at our next slide, we're going to see one of the most common injuries of the rotator cuff, and that's going to be a supraspinatus tendon tear. And in the screen, we see the illustration of a tendon tear on the very top of the ball and socket joints. So if the tendon is torn, what then happens to the ball and socket where the coupling joint existed? So as we move on, we see that you've got a secondary impingement. So as the head slides upward, the humeral head then pops up and pinches on the bone on top called the acromion, and that creates impingement. Now there is some controversy as to whether or not the rotator cuff tear precedes the impingement or impingement causes the cuff tear, but often they will occur together. So they have very similar symptoms. And again, the most common tear is going to be in the supraspinatus tendon on top of the shoulder. So let's look at another illustration that's a little bit closer, and that's going to show us a close-up view with a patient with the arm stretched out to their side. So we see that the biceps tendon and the supraspinatus tendon is being pinched on the undersurface of the acromion, and some doctors will refer to these as bone spurs. And these bone spurs of the shoulder then pinch on the rotator cuff, causing pain or worsening the motion loss in the shoulder. There are some ligaments drawn there, but those are not relevant for the point of this discussion. I'm focusing on the rotator cuff. So let's look at an example of how a rotator cuff left untreated looks like on an x-ray, because normally we don't look at x-rays as a way to evaluate the rotator cuff. But in this illustration, we can see very well on the right-hand side of the screen the difference in the two ball and socket relationships. So you can see the shoulder on the left-hand side of the screen is uncoupled compared to the shoulder on the right-hand side of the screen. And so from this x-ray, we are in fact able to ascertain that this patient is suffering from a rotator cuff tear, because there's no longer a compressive effect from the supraspinatus tendon holding the ball and socket together in the shoulder and coupling the joint. Whereas the picture on the right-hand side of the screen we can see illustrates that the rotator cuff is probably intact because of its relationship to the socket. We can see that joint is actually coupled. So in this, we refer to the left-hand side of the screen as a rotator cuff tear with rotator cuff arthropathy. And unfortunately for this patient, will likely require a shoulder replacement and is not amenable to having a typical rotator cuff repair. So let's go into some of the types of rotator cuff injuries and how they can affect us. So we've already discussed how rotator cuff tears result in a secondary impingement. And as the ball rises upward, it pinches onto the acromion and causes worsening pain and worsens the cuff tear. This eventually leads to arthropathy, and arthropathy is not typically treated with a rotator cuff repair and requires a shoulder replacement. This also leads to active motion loss and then inability to perform our activities of daily living, such as lifting our head above our head, or combing our hair, or putting groceries away, those various types of activities. So what are the signs and symptoms of a rotator cuff tear? How does it affect us? So absent a specific injury, typical rotator cuff tears will present as a dull aching pain in the shoulder, and typically referred to the larger muscle over the shoulder, what we previously evaluated, which was the deltoid. This will be overwhelmingly accompanied by overhead weakness. For example, inability to reach your hand up and comb your hair, use a blow dryer, reach behind your back, reach for your seatbelt, lift a glass up into the cupboard, and typically it's active motion loss, meaning you can't move it, but your doctor can. Another one of the most common signs or symptoms that I see in my practice is patients who have night awakening or a sleep disturbance. They'll roll onto their shoulder, it will wake them up, and this is a pretty sure sign that you either have ongoing impingement or you have a possible rotator cuff tear. So, and one of the most common questions I get is, well, Dr. Gregorius, what causes a rotator cuff injury and why do I have one? So there's an overwhelming statistic of age-related cuff tears. So at age 60, approximately 28 to 30% of the population will suffer a rotator cuff tear without a specific ongoing injury. As we get to age 70, up to 65% of the population has been known to have a possible rotator cuff tear. So why is that? Well, it's typically related to the blood supply, because the blood supply is fairly poor about the rotator cuff tendons, particularly the supraspinatus, which is the most commonly torn tendon. Also related to rotator cuff tears are very commonly sports, such as baseball, overhead activities, swimming, those various exercises where we're going to be lifting weights over our head, work, climbing ladders, gardening overhead, painting, or just repetitive motion. And then, of course, as we suspect, a significant number of injuries are related to just a fall or an accident. So walking from the house and trip and fall. I saw a patient today who had this classic, trip and fall into an outstretched hand and had immediate pain with a pop in his shoulder. and then presented to the clinic with the inability to lift his arm. I could passively lift it, but he couldn't lift it. So his injury is a result of an accident. There are some other factors. Of course, smoking is one of those factors, and then family history. So family history can be strongly related to rotator cuff tears as well. So I'll frequently see a family member whose father or sister may have had a rotator cuff tear, and they also have one. So there's an association there. So many people ask, what happens if I leave my rotator cuff alone? What if I have one and I just ignore it? Well, what's going to happen? So half of the rotator cuff tears, which don't have any symptoms after a fall or an injury, and patients return to sort of a normal status, they become painful or symptomatic within 2 to 3 years of that injury or the acknowledgement of the cuff tear. And importantly, another half of those patients which are painful or symptomatic, they'll progress to a larger period. And what happens is the rotator cuff progresses to a larger size. It's accompanied by atrophy of the muscle because the muscle becomes somewhat paralyzed and it goes from being very elastic like a rubber band to being very plastic like tissue paper. So these are important factors in considering how we're going to treat a rotator cuff because they portend how it may tolerate a suture putting through the cuff. So for example, a very elastic rotator cuff tear that has the consistency of canvas is very pliable and will pull over, whereas one that's like tissue paper, the suture will tear out very quickly. So these are important factors to consider. So what are your options? So you know that you have a rotator cuff tear, you think you do, and you're having night pain, weakness with overhead motion, inability to lift your arm, you had an injury, you need to see your doctor, whether that's your orthopedic surgeon that you know, or whether you're a family practice doctor, or your internal medicine specialist. Most of these doctors are going to be able to refer you for an MRI study or for a higher level of care. So you want to clarify your complaint. So the aim of this talk is to help you identify a possible injury to your rotator cuff tear and then have the appropriate and subsequent steps to follow. So letting your doctor know, clarifying your complaint. So I notice I have night pain, I have difficulty with overhead motion, and then just get started on healing. So even though I'm an orthopedic surgeon and my job is principally surgery, the overwhelming majority of my patients are treated without surgery. So in a clinic where I see 45 patients, 90% of them won't end up with surgery. Most of them will have some form of non-operative management. So I would refer you to the American Academy of Orthopedic Surgeons, which is the board certifying group that almost all orthopedic surgeons who practice, who are board certified, would refer patients to. And there's a lot of really great information on this website. Absent going to physical therapy, particularly in the time of COVID where it's difficult to potentially attend therapy, there's an alternative is attending self-directed therapy. And your doctor can refer you to orthoinfo.aaos.org, and they have a great illustration on some exercises to do for patients that may have a rotator cuff. So you can actually engage in a physical therapy program prior to actually seeing your doctor, and once you see your doctor, you can be referred for a formal physical therapy program. I'm very keen on physical therapy. It's absolutely essential, I believe, in helping maintain the health of a rotator cuff and attempting to avoid surgery. So again, a combination with formal physical therapy and certainly a home-directed program can be very, very beneficial, and it's something I really would encourage you to take a look at. There's a lot of information on the aaos.org website, answers a lot of questions and goes into much detail that's very patient-oriented and very friendly. So why does physical therapy work? Because I get this question a lot. Say, Dr. Gregorius, you're sending me for physical therapy, but I have a rotator cuff tear. That doesn't make any sense to me. And I say, well, look, the rotator cuff, you have 4 tendons of the rotator cuff, so there's some redundancy built in those tendons. And remember, we talked early on about the force coupling mechanism that is very important in understanding the rotator cuff. So yes, the supraspinatus tendon, and we see the back view of our right shoulder here, and we can see that the top tendon is the supraspinatus, but you have the remaining 3 cuff tendons intact. So what you do is you work on the strength of those muscles to help the force couple restore. So you'd be surprised on how many patients that I'll see in my clinical practice that actually doing very well and tolerating non-operative management. And so frequently we'll recommend that you work on these three muscles, the subscapularis, the one in front, and the infraspinatus and teres minor in back. So that will help overcome some of the force couple that is lost when a rotator cuff tears. So this next slide illustrates 4 simple exercises that are done to help restore the function of the rotator cuff. So it's a little bit hard to see, but the first one demonstrates subscapularis strengthening, and that's where your elbow is directly on your abdomen and you're pulling internally at a very slow rate of speed against resistance using a TheraBand. So that's going to work the subscapularis muscle. In our early slides we illustrated that. That's an important tendon helping the force couple. So the 2 tendons in back, the infraspinatus and teres minor, are aided by external rotation against some resistance because that's going to strengthen them. And then the 2 remaining are going to help with the biceps and the low row. So those are 4 exercises that are on the AAOS website that will go into more detail on how a person could potentially gain some improved function and help their force couple and stabilize the shoulder absent a surgical intervention. So another important component of non-operative management that we frequently use in our practice is we use a short-term course of anti-inflammatories. There's a multitude of anti-inflammatories, and every person has a different response to these anti-inflammatories. So if one doesn't work at first, then we stop that anti-inflammatory and try a different one. But we want to be cautious with these anti-inflammatories. So different people respond differently, but there are side effects, including bruising and renal function, kidney problems. So we want to use this for a short term only. We don't want patients on long-term anti-inflammatories. So they have an important role as a non-narcotic mechanism by helping reduce the inflammation so we can do our exercises to help maintain the force couple about the shoulder. So another non-operative mechanism that we use in our clinical practice is injections, the most common of which is corticosteroid. And various steroids have different half-lives or lengths of efficacy. Typically, a corticosteroid injection can last 30 to 60 days, and it helps with inflammation control, as well as diminishing the pain that someone has with their shoulder. And this is really helpful to start to help the remaining rotator cuffs intact. Now, we also need to be careful because historically, some have used corticosteroids too frequently, and with more than 3 injections a year can actually cause the rotator cuff tissue to worsen or to be compromised. So for example, corticosteroid has the effect of weakening the tendon itself. So we want to be cautious and judicious in our use of the steroids. And even though concern for infection, it's extremely low risk to get an infection from a corticosteroid. And there's other promising, adjuvant therapies that we refer to as regenerative medicine, such as platelet-rich plasma and stem cells. These types of injections are not yet FDA approved, but they're in common usage and ubiquitous to orthopedic surgeons' offices across the United States. The disadvantage is they're expensive, but they've shown a lot of promise, so we're very encouraged by this, another technique that's without surgery. So what if pain continues? How long should you wait? Physical therapy and anti-inflammatories haven't worked. The injection helped, but the pain comes back. Well, at this point, we really need to get an MRI to discern what type of injury you have about the rotator cuff. And you want a referral to an orthopedic surgeon who has specialty training in shoulder. So this is an important distinction. So we want to find someone who's familiar with shoulders, and that's an area of their expertise. So what does an MRI do for us? So oftentimes patients will be confused the difference between an MRI and a CT scan and a regular X-ray. So the MRI is really good at showing soft tissue injuries. It shows impingement in the rotator cuff tear, as we see in this slide. It also helps differentiate between acute injuries versus chronic injuries. So that's important because if we see a chronic injury and we see that it's been there for a long time, it may change the recommendation for the type of care that we provide to the patient as opposed to an acute injury. So an MRI is an essential next step in management, and based upon the clinical presentation of how you visit your doctor, we may get an MRI right away, or we say, no, let's wait for an MRI until we think which time you've failed the other modalities. So surgery, obviously I'm a surgeon, and this is how we treat patients that have failed conservative management. So there's a multitude of ways, and I want to be clear here that there's no right or wrong way to treat a rotator cuff. In my training and my fellowship, I was trained to use an all arthroscopic technique, and that's what I'm most comfortable with. Surgeon preference is a very important part, and I think it's important that as patients, when we talk to our physicians, we don't want to encourage our doctor to change their practice to accommodate what we think is the right technique. We want to ask our surgeons, which technique do you use and why do you use it? So there's various there's procedures. There's an open procedure, there's a mini open procedure, there's mini open with arthroscopic assistance, and there's all arthroscopic. But again, it's an important point that surgeon preference is what's most important, and you're going to get a good result based upon your surgeon's experience with his or her specific technique, and that's based on their training. So my preferred technique is using an all arthroscopic repair. I was taught in my fellowship and residency that if it can be fixed, it can be fixed arthroscopically. And in my hands, that means less surgical time. I have a better visual field, and I can use a knotless technique. So here on the right side of the screen, we have a large to massive rotator cuff tear. And you can see in the slide B, what we're doing is called a margin convergence. We're just pulling those two margins together, and we're using an arthroscope through a little poke hole to pull that tendon back. And then in the final slide in D, we see that the tendon's been pulled back, and we have what's called a transosseous knotless equivalent repair. So it's equivalent to an open repair, but it's done through the arthroscope, and it doesn't have knots. So that's my preferred technique. This is an example of an open, and for some surgeons, they prefer this technique because it gives them a better visual field. Again, this is important that it's patient preference, and one is not better than the other. It's what's best in your surgeon's hand that counts. So an arthroscopic, and this slide illustrates, again, a transosseous technique, and the two video you see the video camera in the back of the screen, and then you see the instrument in the front part of the shoulder. This is, again, a right shoulder, and it's illustrating a transosseous knotless double row rotator cuff repair. So these surgeries take about 45 minutes to an hour to do. They're done on an outpatient basis, and they're typically accompanied with an anesthetic block to reduce the use of opioids and reduce the need for postoperative pain management. It's a very effective strategy in helping our patients get an early recovery. So what's the rehab like? So typically we see our patients within 1 week of the surgery, and we provide them with pictures or video of the surgery. It's a sling from between 4 to 6 weeks. And then physical therapy, again, we go back to physical therapy because now that we've got a repaired tendon, we want that to work in conjunction with the remaining functional tendons to recreate the force couple. So key times are 3 months, and at 3 months there's a full active range of motion. And by 6 months we considered the vast majority of cuffs to be healed, and at 12 months you're back to all your activities. But typically by 6 months you're doing everything you want to do, including golf and tennis, back to your swimming and your various sporting activities. So again, I want to thank Hoag Orthopedic Institute and the opportunity to be here tonight. I can be reached at Gregorius at calortho.org, at California Orthopedic Specialist. And if they have a specific question, you can always email me. I'm happy to speak to you over the email, time permitting. And I look forward to seeing you in the clinic. Thank you for the chance to talk with you. So I do about anywhere from 140 to 150 rotator cuff arthroscopic surgeries a year. It's the most common surgery that I do in my practice.
How many years have you been in practice?
So I've been practicing after my fellowship for 15 years. This will be my 15th year in practice.
What is the most common misconception about these types of injuries?
Yeah, so that's a really good question. I think the common misconception is that surgery is really difficult to overcome and that it would take too long, and so a lot of people put off surgery. So surgery can be done really well if you have a good understanding of the options, and that includes non-operative management. So again, you always want to start with the right type of conservative treatment, then followed by the correct surgery for you. And so, yeah, I mean, I think a big misconception is it takes too long to heal and it's not worth it, but that's a mistake. You really want to get in and discuss your options before you make a decision.
What is your fellowship in?
So I did a fellowship at Stanford in sports medicine, which is essentially euphemism for arthroscopic surgery. So that includes a shoulder arthroscopy, hip arthroscopy, ACL reconstruction. So what you think of sports medicine, including shoulder replacement.
Can physical therapy reverse a surgery-required diagnosis?
Yeah, so actually, in some cases it can. So in someone who has, for instance, rotator cuff arthropathy, and they have a significant tear, and they have a fall, for example. They come in and you see them, you get an x-ray, you say, well, it's probably going to need a shoulder replacement because the rotator cuff tear is so big. But I will frequently see those patients and inject them, get them to physical therapy. They'll return with back to their baseline status, which doesn't make perfect scientific sense, but they're able to return to be very functional. So again, that's a good example of non-operative management. All right, well, thank you very much again for having me this evening, and take care.